Okay, so we are talking about pupil expanders. So it's BHEX and other pupil expanders. So courtesy, what we will do is we'll talk about other pupil expanders first and then the BHEX. I'll just clip this. We are not talking about iris hooks. So this is the Malugin ring, which is the standard of care. Now there are issues with the Malugin ring. There are pain points that it's a biplanar device and it requires a little bit of a learning curve in terms of loading and engagement with the pupil margin. Well, that even if you learn, there are certain unpredictable factors like the when you remove the ring, it kind of crushes the iris because of the mechanics that are involved in that. So that's the scrolls, and this is, you're very familiar with this. So we'll just go to the removal. That is where, yeah. So when you remove the ring, engaging it into the injector and drawing it in is a ask. It requires a little bit of skill, and that's when you see you're struggling over there. And look at those two arrows over there. That's where in those scrolls that distal scroll, it can get crushed, and here while retracting it can again break over here. So the reason being,
The scrolls are like torsion springs with a gap and act as a compression spring too, and hence can crush or release the iris unpredictably.
It is fundamentally wrong to attempt inserting a biplanar scroll through a slit incision. That is why an injector is required to prevent snagging of the incision.
So we need to understand that the injector came as a kind of remedy for the scrolls, the design issues. So this is a video by Thomas Oetting, and it's there on the net for a long time. And this shows the issues that were there with the Malugin ring. Now most of the issues have been overcome, but still there is a glued joint and it can break, and that is a concern in every surgery that you use. And if it does crush the iris unpredictably, it is a thing that is going to be very intimidating for every surgeon. This is the APX, didn't really do great. It looks very bulky and pretty crude actually, though it's gone through like a lot of iterations, but still it has not really been very popular. The Expand NT, it's a nitinol ring, and with the forceps it was really difficult, so they moved on to injector. But even with the injector, the control is pretty poor and it's a kind of jerky implantation, so that really didn't again become very popular. So this is a Beaver Visitec eye ring. Now this again has a larger vertical profile. So in the anterior chamber, if it's shallow, see this, if the ring is going to be left loose in the anterior chamber, it can knock the corneal endothelium, and that is a risk that we have. So Canabrava's ring is a PMMA ring, pretty rigid for the anterior chamber, and well, it can work in a case or two, but it's not really the go-to device for most surgeons. Now, we conducted a survey in 2020, August. That was the time when people were willing to answer surveys. And we were happy to note that the BHEX was doing as well as the iris hooks. Maybe the respondents were, the sample size was small, but it was very gratifying to see, at least among pupil expanders, the BHEX was doing the best, despite the fact that the BHEX was priced 4 times more than the iris hooks. So the BX is a simple pattern, simple design. It's flat, hexagonal notches and flanges. The beauty about it is it's resiliently flexible and it's very, very thin, 75 microns or 0.075 millimeters, and it's very flexible. So the difference is in how the pupil margin is engaged. The device, the BX, is in a single plane, and all other devices are biplanar. So here the iris bends at the notches, but in other pupil devices the pupil margin actually remains the same. So tucking it under the flanges under the pupil margin is very simple. It's the using a forceps comes intuitively to every eye surgeon. It's not such a big deal. And like I said, the device is in a single plane and the iris bends at the notches. Removal it's probably the easiest among all devices. Just grab that flange and advance it, disengage and pull it out, and it can be removed through a side port incision. This is the forceps recommend for that. So this is a 1.8 to 2.2 that we recommend. There are a lot of people who do coaxial MICS. So that was what we were saying. Actually it goes in pretty easily through a 1.5. It is just a walk in the park. It glides into the anterior chamber very easily. Tucking the flanges is easy. And the ultra thin BX allows so much more space in the anterior chamber that your phaco probe can move around easily, and including your IA cannula can also move around. So the excursions can be actually without any fear. That's the phaco probe, and look at the excursion of the IA probe. You can, with most other devices you won't be able to do that. So I think we will move a little fast over here. Okay, so again, it doesn't come in the way of the IOL implantation. The nozzle easily clears the capsular excess margin, and you can go under the IOL, remove the viscoelastic. It's really not a concern. Like I said, removal is very easy. Just disengage one flange and draw it out, and it just walks out. And you have a wonderful round pupil at the end of surgery. Now, this is what we presented at the ASS meeting last week, or rather this week only. So this is a 1.2 incision which we can use to insert the BHEX, and no device can do that. So if we are working towards smaller incision coaxial phaco in the years to come, we don't know where we are going to go. This will be the device that will be available. Yes, you just need to position that flange a little differently so that it's oriented well to the incision, but it can go in through a 1.2 incision. As far as removal is concerned, again, in a tight situation, you would like the device to come out through a very small incision. So a 0.9 millimeter side port incision is good enough to remove the BHEX. So if you are faced with IFIS and the iris is prolapsing, this would be probably pretty invaluable, and really no other device can match this particular incision size. What we noted also in the course of one of the studies was that we could use the BHEX for remove the BHEX under irrigation as well, because a lot of surgeons these days are taking to hydroimplantation, that is injecting the lens without any OVD. So that is also possible. How big do you want the pupil to be for any device? Well, I would say 5.5 is a very good size. You can chop even the hardest. In fact, with iris hooks also, you shouldn't be stretching the pupil any more than that. That way it will be cosmetically disfiguring. Look at this particular video by Dr. Deepak Megur. It's a pretty hard cataract, and like it's just about 5.5, this pupil. It just can't get bigger than that. But it's a hard cataract. All you need to do is chop it into small fragments, and you have full control over those fragments, and you really are not stressing the capsule margin or the pupil margin. So intraoperative bias is another place where the BHEX will probably score much higher than other devices. The Mulligan ring, when you see the scrolls through a top view, you really can't see the gap in the scrolls. So you're never sure what you are engaging, whether that you're engaging the capsular excess margin or the pupil margin. But if the BHEX notches are facing you, and it's with direct control that you're holding the flanges and you're tucking them. And as you tuck those flanges and you push them to the periphery, you have instant confirmation that you've not engaged the capsular excess margin. So that is and even if you have engaged, you can see it and you can withdraw and again go back.
And welcome to the 20th annual AAO Spotlight on Cataract Complications. And this ring is very popular in Asia, I believe, and in some European countries. And again, it's FDA approved, and he calls it the BHEX ring. And it's really, really thin. So this ring comes out really easy. It's flimsy, it's thin, and we pull it right out.
So Dr. David Chang was kind enough to show it in the AAO meeting 2021 at one of the most prestigious shows, that Spotlight on Cataract Surgery. And American Academy of Ophthalmology also has another video on the BHEX being used in an eye with tube shunt. That's by the Professor Deepak Edward and his fellow Michael Henry. So this is, again, if you see, only one incision has been used, and it's been used to tuck all the flanges. And look at the third flange, how it goes around the tube shunt that is there. No device would be able to do that. It's so thin, and it allows you so much room, so much control, and that way they could get past that tube shunt. It's been used in posterior segment surgery as well. This is a wonderful award-winning video by Dr. Devdolal Chakraborty. So I won't go into details. It's available on YouTube. So these are complicated cases where they could see the periphery and break and do the surgery quite uneventfully. So this was, I think, shown 2 years back. And in Gurgaon, they won an award for this. So which would be your pupil expander depends entirely on your choice. If it's a rigid pupil, you will have to tear that fibrotic band, whether you do it by stretching or by using a device. It's your choice. Yes, the BHEX is a delicate device. It can't really, that's the trade-off. You cannot really stretch it. So you'll have to use a Kuglen hook. These are our publications, and I would strongly recommend that you look up this. This is available on our website and pretty easily available on social media as well. Thank you very much for your attention. Thank you, Dr. SAJJAD, for this wonderful opportunity.
Yeah, so tell us about whether you're wary of using these rings when the zonular support is not good.
Yes, that's a wonderful question. That is probably the only place where I will choose iris hooks over BHEX, because So the BX, any pupil expander that you use is going to remain central. You may push it around for a while and see, but with iris hooks is what you can do is give asymmetric expansion. If I want one side to be stretched too much and the zonal array, I can see that. So I would use iris hooks. I would really not go for a pupil expander.
Thank you.
Thank you. Thank you very much. I'll just run to the other hall.
Yeah, thank you very much. So, any questions? Jojo? So we know that small pupils are an issue for all operating the cataracts, and the use of tamsulosin, floppy irises, and small rigid pupils, overall it has, in the number of cases has actually increased. So we need to know how exactly to handle the small pupil, because safety is most critical. You might be an excellent phacosurgeon. You'll But the adequacy of the pupillary size is most important and most vital for a safe surgery. So Dr. Snober is going to present to us pharmacological pupil expansion, various considerations before we start off handling and operating a patient with a small pupil.
Slideshow. Use slideshow. Okay. Good afternoon, everyone. I will be talking about the pharmacological aspect of the pupillary expansion. So first, coming to how does the pupillary dilatation take place? The constriction of the pupil occurs via iris sphincter muscles, which is controlled by the parasympathetic pathway. And similarly, the pupil dilatation occurs via iris dilator muscle, which is controlled through the sympathetic pathway. It's an autonomic nervous system pathway which begins in the hypothalamus locus areolus, and via the superior cervical ganglion, it innervates the iris dilator muscle. The iris dilator muscle, these are the radial muscles which have got sympathetic innervation, and when stimulated, they release the noradrenaline, which then act on the alpha-1 receptors. That's why during the state of fear, excitement, or arousal, the pupillary dilatation takes place. So why do we need to dilate the pupil? We need to dilate it for various diagnostic procedures like refraction, to have any nuclear grading of the cataract, and for fundus evaluation. Surgically, we use it for every intraocular procedure, and with cataract surgery, it has become paramount importance because with the recent advances in the phaco techniques, the ease of this pupillary dilatation, it has improved the post-operative outcome, and there are less complication rates. It has become one of the prerequisites for safe cataract surgery. Appropriate mydriasis and inflammatory control, they are key to a surgical outcome. So, as you already know that the pupillary size of 5 to 5.5 is the acceptable size to make a good capsulorhexis of about 5 mm. But poorly dilated pupil, it is one of the most common difficulties that is faced by the surgeon. You can see here's a poorly dilating pupil, and with the installation of the mydriatic, the pupil dilates. It is not just a geometrical issue which limits the access to the surgical field, but is also there are several factors that affect the pupillary dilatation, which cause an increase in the blood aqueous barrier, and we did know that after a poorly dilated pupil is present, there will be increased risk of post-operative inflammation. Some of the common causes are prior ocular surgery or trauma, chronic uveitis. In chronic angle closure glaucoma, where the patient is on chronic meiotic therapy, we have to start at 3 weeks prior to the surgery, in pseudoexfoliation syndrome, and in senile sphincter sclerosis. In the systemic causes, diabetes mellitus is one of the most common cause where there is glycogen deposition, neurosyphilis, and substance abuse. In the drugs, we have tamsulosin, which is commonly used for the treatment of BPH. We have substance abuse like phenytoin, morphine, heroin. IFS, when there is systemic administration of alpha-1 receptor antagonist tamsulosin, there occurs billowing of the flaccid iris stroma to normal intraocular currents, propensity for the iris prolapse to main incision and side port, and there is progressive pupil constriction. So in case what are the challenges which are faced by a surgeon during the surgical procedure? The small pupil gives less surgical space, which leads to lesser capsulorhexis. Then there are higher chance of anterior capsular tear, posterior capsular rupture, increase in the vitreous by a factor of 2, and increase in the postoperative inflammation. So whenever we know that there is a small non-dilating pupil, we have to take the steps to prevent it. Careful preoperative evaluation, we have always to know what is the cause of small pupil, and then we have to take a careful medical and ocular history. Following an algorithm can be helpful. Then the pharmacological dilatation, this is the standard practice. We have to achieve maximum pharmacological dilatation. We got topical mydriatics, topical cycloplegics, and topical NSAIDs. Then intracameral mydriatics and viscomydriasis. The preoperative mydriatic regimen that is followed is phenylephrine, tropicamide, cyclopentolate. Atropine is not commonly used because it has got a long duration of action. The standard protocol is sympathomimetic mydriatic like phenylephrine in a concentration of 2.5% and parasympathetolytic cycloplegics, either tropicamide or cyclopentolate. And studies have shown that NSAIDs, especially ketorolac in concentration of 0.5%, help us to prevent the intrameiosis. There are certain intraoperative measures which we can follow after the topical administration. Midriasert is a new drug that has come in the market. It's an FDA approved. It consists of an oblong-shaped semi-permeable capsule which has 0.28 milligram of tropicamide and 5.4 milligram of phenylephrine. It is placed in the inferior fornix 60 minutes prior to surgery. We have to take care that make sure to remove it before the surgery. So phenocaine is the drug that has come in the market. It consists of tropicamide, phenylephrine, and lignocaine. It can be used intraoperatively. This is a small non-dilating pupil. We can see the pupil dilates beautifully intraoperatively. The placement. Episugarcaine, that was launched by Joel K. Sugar in 2006. It is especially helpful in patients with IFIS. It overcomes the action of alpha-1 blockers such as tamsulosin. It consists of 4% lignocaine, which is then diluted with 1:3 BSS. But what is the disadvantage of any homemade cocktails? There can be dilution errors, accidental use of medications which are containing preservatives, which can lead us to toxic anterior segment syndrome. So there are certain FDA approved drugs like Midrine, which has tropicamide, phenylephrine, and lignocaine available. Non-preservative epinephrine, it can be used. What is the problem with this intracameral? That there is constant washout with the irrigating solution. So another thing is we can mix it in the irrigation solutions. They have been proven to be non-toxic to the corneal endothelium. A combination of phenylephrine 1% and ketorolac 0.3%, which has been launched by the name of Omidria. It has been recently approved by FDA. It prevents intraoperative meiosis and postoperative ocular pain. It is also mixed with the irrigating solution, and constant irrigation can be done. After we use the maximum topical medication and then the intracameral mydriatic, still the pupil is not dilating, the next step is to go for viscomydriasis. We use OVDs, the sodium hyaluronate 2.3%. The advantage is it causes intraoperative pupillary dilatation and the physical barrier to decrease the iris billowing and prolapse, especially in IFIs. But viscometrias is more successful in low phaco settings. In case we have to do high vacuum settings, there was a technique which was formed by Steve Arshinoff known as soft shell technique. In this, we put a dispersive viscoelastic which coats and prevents the cornea, and then a cohesive viscoelastic to flatten the capsule. So to conclude, topical medications and intracameral medications, they help us to achieve dilatation in 90% of the cases. We have to know everything best that is in pharmacologically. The first thing is to ensure maximum dilatation before starting the surgery, topical mydriatic drops, topical NSAID drops. Next is we have to have an optimal dilatation, surgical spawn soaked in 10% phenylephrine in the inferior fornix 30 minutes prior to surgery, but always make sure to remove it. And then we have to maintain the dilatation during the process of surgery. We can do it with episugarcane, midraine, mydriatic with or without NSAID in the irrigating fluid. After that, intracraneal preservative-free phenylephrine, OVDs with low flow and vacuum setting, bimanual sphincterotomies and bimanual stretching and sphincterotomies after we're done with the pharmacological part, and then the pupillary expansion devices. So we always need to have a small pupil management algorithm. It will help us to achieve adequate pupil size with minimal risks. So know your pharmacological agents, then mechanical expansion devices, and we can get optimal surgical visualization while following this algorithm. Thank you for your patient hearing. Thank you.
Any questions?
Congratulations for such a wonderful talk. Any experience of using ketorolac 2 days or 3 days or ibuprofen and its effects on pupillary dilatation?
Yes, studies have shown that ketorolac, it does not help us in the preoperative dilatation, but yes, definitely during intraoperatively in small people, like if we it is a cyclooxygenase inhibitor, so there is basically inhibition of the prostaglandin. So if you starting using it in preoperatively, what can happen even if there is inadvertent touching with instruments, so there will be less chances of intraop meiosis during the procedure.
Thank you, Dr. Snober. Now we're coming to the less theoretical part. So let's hope this is a little challenging, because we're talking about the big challenge of the small pupil. So, इसमें audio लगा? Audio लगाओ. We need everybody to sleep after lunch. So we're talking about surgical considerations, how to handle the small pupil when we are confronted with one. So here you see a pupil which is not that great size. We see a little floppiness. 2-3 things are going to happen here, and they are going to be a challenge. One is that this pupil will restrict the size of our capsular axis. So if our pupil size is big, we can shape a bigger axis. But here, even though I've gone very close to the pupil margin, but even that has restricted the pupil size, then we need a lot of surgical expertise. This is a video of my surgery around 19 years ago. I didn't know exactly how many things can go wrong. You can see I'm very close to the pupillary border, holding the pupillary border away, and then taking these chunks out. So most of the times when you're attempting something like this, you have to be right in the center of the pupil. You cannot be moving away from the center. IA is another matter. You can leave some chunks of nuclei there, and you might not be able to see them, and IOL insertion might also be an issue. So when we are talking about attempting to operate through a small pupil, we're talking about a higher level of expertise, especially if you are not moving the iris away, and I'm using a Y hook here. We just break the book, undiluted. Ports for the iris hooks. So once I made the ports for the iris hooks, and I'm using finucane after that, what will happen? Because there's an element of complicated cataract. I thought this patient might have, because the patient had keratouveitis, so I didn't even expect this pupil to increase in size. And pre-operatively, when we have conventional regimens of cyclopentone, this had not been done. Why some irises would behave better with posterior sinus after issue, then we know that unless we remove the posterior sinus, this pupil is not going to expand no matter what we have intracameral perioperative. Again, this is a little challenging because you can see the pupil size is not changing, especially if the population is certain amount of experience sorry. So this is another case where you can see that I had started first, then placed the hooks, and then finished the case safely. One point I wanted to show you here was that here, after I finish the nucleotomy, do a cleanup, you can see that again, this exercise might not have been optimal, but considering the difficulty with which I overburdened myself initially, you can see now I'm placing the IOL here. But before that, you can see the tenting there. Yeah, the iris is tented there. So when you go in, you can actually hurt the iris there. Iododialysis, sphincter tears. So you come out with these two hooks first, and this settles the iris down, and then you go ahead and you place the IOL after that. So here the pupil is coming down after I have done the nucleotomy. It's not after access that I made a decision. Now it has come down. Now, because it has come down now, I cannot allow the cortical matter to be there. So I'm putting in the hooks at this point. And you can see adequate exposure and then done nicely. And in patients like these where you'll have to think about toric IOLs, because those corneal scars are giving them big problems here. I'm doing a posterior synechia. I'm trying to remove them with the Sinski hook. Now those are removed, and then I seem to have a reasonably good pupil, you see, and I go ahead with. But one has to understand that when we are cutting these posterior synechia, you see reasonably good pupil, but the issue is that I have caused a lot of trauma there, and floppiness of the iris is an issue where many things come into factor, and one of the reasons is when we have handled the iris. If you have handled the iris, surely this iris is going to be a little floppy. As soon as the rexus is done nicely and smartly, after that, when the nucleotomy time comes, you can see the pupil is coming down. Not only that, where the synechia were there, you can see the iris is coming again and again into the phacoprobe. So and this is my incision site. So I have no choice but to expand this pupil, and the only way of expanding this pupil at this side, this case, would be the iris hooks. You can see we have put in the iris hooks. Now we have adequate exposure, and then we go ahead and operate. Complicated cataracts like these, where there's a fibrous membrane around the pupil, small pupil, you can see I'm going behind the iris and putting the trap and blue there. This is a very important point, because if I stain first, only the central part might get stained. Some trap and blue might go from the sides, but it is good to go under the iris and place the trap and blue. Here I'm trying to remove this membrane, but it's causing too much stress, so I leave it there. I go in again, I try to see how much of posterior synechia there are. There's not much there, so I know all this small pupil is related to this membrane fibrosis of the pupillary margin. So I go in again and use 2 Y hooks, and this has worked very well in my hands. And in those people who try this, it surely causes some amount of iris trauma, but same amount of trauma you would see with iris hooks also when they are placed. And there is also about what Dr. Suin was just now talking, that the Bhattacharya BX ring perhaps gives the least amount of trauma. You can see sphincter tears there, but it has given us adequate space. It has given us adequate space, and we can now see that we can operate this case through a reasonably safe pupillary size. In this case also, like I told you initially, when I stretched the pupil bimanually, you can see the pupil had become big size, but it had become floppy. And when it became floppy, it's coming in the eye probe again and again. So I had to put in the pupillar expansion rings, and that solves the matter. And floppy iris, very dangerous. You can see here. I'll show you again. The first case I showed you was around 18 years ago. I was not scared of operating a patient like this with a smaller pupil. Now I rethink again. You can see that this iris is really floppy. Now I've gone and done a reasonably good rhexis, but when I'm going near the pupillary margin, you can see this iris floppy. I should have stopped here. It has come in. Now I've caused some amount of sphincter tear. Now there's no question of moving any further because the pupillary size also has come down. Pupillary size has come down. The iris is floppy. Now we should go ahead and think about something else. So I've put iris hooks now, and this has given us a reasonably good exposure, and it has kept the iris away. And there are cases like these where the rhexis is very important. This is subluxation. You can see here I'm placing multiple hooks. This is only possible if you are seeing your rhexis and the pupil is wide enough. You can see many hooks, capsular support hooks and iris hooks have been placed, and then this case has been completed safely. I thank you all for your kind attention. One speaker of ours could not come. Dr. Suvin already discussed this. We started 20 minutes late, but I hope that we have finished in the right time for the next session. Malignant rings, again, great tools. I always used to enjoy this before the Bhattacharjee ring came, and in good hands, reasonably okay experiences. But I guess BHACs and Made in India should be our choice now. And I'll finish on this. This is a video from my friend, Dr. Deepak Magur. And this is really easy. Thank you all for your kind attention. It was a pleasure being here.